Thank you so much. I appreciate this opportunity. And so can we all stop being afraid of estrogens? These are my disclosures, and the one that's of note is that I'm the guidelines panel chair for the AUA's Genitourinary Syndrome of Menopause. I do not speak to you today as the chair or representing the AUA, but simply as one of your SMSNA colleagues. And I'd really like to acknowledge the fact that this guideline exists and that we're having this conversation today. So thank you to the AUA, to the SMSNA, to my collaborators, Dr. Lee, Dr. Rubin, and of course to the esteemed Dr. Goldstein, who pioneered much of the work in this field, and also to Dr. Burney for this invitation to bring this forth to the community. And really, thank you. Thank you for being here and thank you for caring, because why are we here? We're here to advocate for our patients, to remove barriers for treatment and improve their quality of life. So as Dr. Goldstein mentioned earlier, in 2014, GSM became a terminology through ISWISH and NAMS, really to improve our accuracy, public acceptance. The difference between utilizing the term vulvovaginal atrophy and GSM really changes and decreases that social stigma. And it's a very broad collection of signs and symptoms that include everything in the entire vulva, vestibule, vagina, including dyspareunia, pain, urgency, dysuria, and recurrent infections. And it's associated with imbalances of all the sex steroids, but most prominently estrogen. And these are urology patients, and we know this. We've treated them for long periods of time for comorbid diseases that really are sequela of GSM. And it's incredibly prevalent, but when we think about it, we think about postmenopausal women, but we need to really broaden our concept. These are perimenopausal women, women on oral contraceptives, even my transgender men. We need to think about all women, and particularly cancer survivors. Of course, the vagina has this stratified epithelium, muscle, and adventitia, and the dominant regulator of the physiology is estrogen. So lack of estrogen has very dramatic changes to the entirety of the vagina and the vestibule. So we're going to go through a couple of scenarios to see what actually happens in your clinic. And Mrs. S was 77. She came in. She had recurrent UTIs, frequency, urgency, maternal grandmother who had breast cancer. And on her physical exam, it was very typical for what you might see in GSM, with pale, fragile epithelium that was thinning. And so it was fundamental to supplement estrogen for vaginal tissue in her. So we prescribed it and told her to use it 3 times a week. And she comes back 2 months later and says, well, I used it for a week and it was really messy and it was very expensive. So she stopped. Your education of patients, and that's why we're here today, to give you tools for education, is essential if you want their wellness, if you want them to adhere to these types of therapies. If it's too expensive, if it's messy, if it doesn't get opened, if it doesn't get refilled, it's not going to do the patient any good. And there are a variety of treatment options now that we have had around since the 1970s, including DHEA. So we give her estrogen tablets. We change the modality of therapy. She comes back for follow-up. She's had 5 more infections, and she's not been using them. And I'm like, Mrs. S., why are you not using them? And she says, Dr. Kaufman, why are you trying to kill me? Why are you trying to give me endometrial cancer, cardiovascular disease, breast cancer, and dementia? Why? So what is your next step when this patient comes in to your clinic? Are you going to switch her to a moisturizer? Are you going to tell her she needs a biopsy? Well, I'm going to tell you today that you can reassure her about class-specific estrogen labeling, because when you give topical estrogen, there is a very small spike that lasts for about 8 hours for systemic levels. And indeed, when we look at very large randomized clinical trials, it's no different than what you see with placebos. So over 12 weeks of time, it does not increase the estrogen levels that are circulating in the system. And we need to change product labeling. And CR pal Rachel Rubin are working hard with legislators just to do this. We must change product labeling for testosterone. We must change product labeling for estrogens so we can use them thoughtfully and so patients and providers are not afraid. But what about cardiovascular disease? In the Women's Health Initiative observational study and the Nurses' Health study, it turns out that for postmenopausal women, cardiovascular disease or cancer were not elevated. So you can give that patient some reassurance regarding those warnings. And in this study of patients who were taking vaginal estrogen and had breast cancer, or were going to, whether they developed breast cancer, it was not associated with increased development of breast cancer. And this was for duration, intensity of use. So again, reassurance regarding safety of treatment and development of breast cancer. And what about patients who did have breast cancer and survived? This was 49,000 patients, and about 5% were utilizing estrogen after the diagnosis. No evidence for increased breast cancer-specific mortality, and actually a small decrease in mortality for patients who were on estrogen. So again, reassurance. What about my second case, Mrs. J? She comes in, she's got burning, she's got dysuria, she's had a hysterectomy, she's had breast cancer, and she just finished a selective estrogen receptor modulator treatment a year ago. So here's the patient, estrogen receptor positive breast cancer, status post-tamoxifen treatment. What do you think you're going to do? Gonna give her a laser? I'm gonna give her vaginal estrogen. Then the data is going to support me. So in patients who have had a history of breast cancer with a history of breast cancer with estrogen receptor positive, there was no increase in breast cancer recurrence. So again, reassurance regarding the safety of treatment. Now this one case, Mrs. W comes in, she has estrogen receptor positive breast cancer, but she is on active aromatase inhibitor treatment. This is the one situation where I'm probably going to recommend vaginal moisturizers. And of course, these are all done in shared decision-making capacity, multidisciplinary, along with their oncologic providers. Because of this Danish observational cohort study that actually demonstrated in over 8,000 women that there was an increased risk of recurrence for breast cancer, but not an increased risk of cancer-specific mortality. But even in that occasion, it's going to give you some pause. So again, this is for patients on active aromatase inhibitor therapy. And what about gynecologic cancers? Although this was a smaller study with about 250 women, there was a vast number of different types of gynecologic cancers, no evidence for cancer recurrence, no evidence for increase in thromboembolic disease. So again, reassurance regarding safety of treatment, low-dose vaginal estrogens. Here's a patient who's on some medications for lower urinary tract symptoms. She's on vaginal estrogen, yet she has persistent vaginal vestibular pain, dyspareunia. What's your next step here? Don't forget about the pelvic floor in any of these women. Patients who are on systemic therapy still require vaginal estrogen therapy. Always screen for pelvic floor dysfunction, and you can use other compounded treatments, including testosterone, for these types of symptoms. So overall, I hope this has given you a little idea to appreciate the prevalence and impact of GSM and reassurance regarding safety of treatment. So watch out next year for AUA guidelines and advocate for our patients, improving their quality of life. Only those who seek are going to find, so really appreciate, thank you for seeking.